Mhm. Cyber. Okay. So, all right. So we'll begin our session now. Welcome to day 4. And today we're going to be discussing data interpretation and biophysics. And I hope I'm audible. Sanusha, I need some feedback.
Yes, ma'am. Please start.
All right. Okay. Okay. So today's session is going to be just for 2 hours, unlike your marathon sessions in the previous 3 days. So we're going to try and cover as much as possible, which was asked in the July 2025 exam. So what is important in data interpretation as far as traces are concerned, as far as lab results are concerned, and imaging is concerned, is the most important part is CTG. Okay, so CTG is the hottest topic. And also there have been some changes in the guidelines probably a year and a half back. So that is why a lot of you are concerned about it. But really, it's not much of a change, and we will be discussing it. What is important in the CTG? The decelerations, the sinusoidal pattern, and the acute events. So you're supposed to rule out acute events and then move on to definitive actions. Then, of course, we are going to be discussing a little bit about hemoglobin, electrophoresis, and high performance liquid chromatography. There have been questions in the past on these. They've actually given you slides. So let's see how clearly we can cover it today. Then, of course, a little bit about the lab investigations and a little bit about the imaging, ECG, and urodynamic interpretation. Now, at the outset, let me tell you, it's the first time I'm using my iPad for a presentation. So I hope I don't fumble, and just bear with me for this. All right. So moving on to CTG interpretation, and the famous mnemonic is Dr. C. Bravado. So when we see a patient in our labor room and the patient is having a CTG, so a CTG of a primary gravida with having no, previous episodes. She doesn't have any reduced fetal movements. She doesn't have any preeclampsia, no high BP, no sugar. She's a normally built lady, so conceived normally. Everything is just, insignificant. So that risk of that patient, okay, is not going to be compared to the same gestation lady, same age lady who is having preeclampsia, who's having gestational diabetes, or the baby has FGR, the fetus has FGR. So basically, the doctor is defining risk. So you have to define the risk in the mother and the fetus. Contractions, Dr. C. Bravado. So C is for contractions. And how many contractions are there in 10 minutes? So what is normal is up to 4 to 5 contractions in 10 minutes. Anything more than that is not normal. Okay, so that goes into what we call the amber zone. Okay, so everything which is normal is going to be in the white zone, and anything which is abnormal is going to either go into the amber, and which is pathological is going to go into the red. As far as contractions are concerned, it is only amber. Okay, so anything more than 5 is amber. There is no red category for contractions. Then the baseline rate. Okay, so Dr. C. Bravado, BRA is for the baseline rate, and we all know that the normal baseline rate is 110 to 160 beats per minute. There are times when baseline rate of 100 is also considered normal, and that is in a post-term pregnancy. All right. So then we go on to the next one, which is variability. The normal variability is between 5 to 25 beats per minute. And this is the single most important factor in the CTG, which is going to tell you how the fetus is doing. Okay. Then accelerations, of course, presence of acceleration is reassuring. Okay. So what are accelerations? Accelerations is an increase in the baseline heart rate of more than or equal to 15 beats per minute for more than or equal to 15 seconds. Why have we put this time over there? Because if it is more than that, okay, over a period of 10 minutes, if the FHR goes beyond a particular rate, then the baseline has shifted. Okay, then we move on to fetal tachycardia. Then it is no longer an acceleration. Then we have decelerations, which may be early, which may be late, which may be variable, or which will be prolonged. We will come to that. And then after seeing all of these things, we will form overall impression of how our CTG is. Now, baseline is the mean. When we see the trace, it's the mean FHR to the nearest 5 beats per minute. Okay, so if it is around 130, it will go up to 135, it will come down to 125. So plus minus 5 beats per minute, and that is going to be your baseline rate. You have to have a 2-minute or more region of the CTG in the 10-minute period. So to be able to ascertain that this is the baseline rate. Suppose there is no 2-minute period, whether it is continuous or discontinuous. Okay, so it might be 1 minute here, 1 minute there. In between, there will be an acceleration or a deceleration or whatever. Okay, so you have to have a 2-minute period at least to be able to know what is the baseline rate. If you do not have that, then the baseline becomes indeterminate. Okay, now let's just categorize each feature. So baseline is reassuring, like we discussed, between 110 to 160 beats per minute. It is non-reassuring if it is 100 to 109 or 161 to 180. And it is pathological if it is less than 100 or more than 180. Now again, define the risk. If the patient is 41 weeks, okay, and the baseline rate is around 105, okay, but everything else is normal. The variability is normal. The accelerations are present. There are no decelerations or at the most early. Then you do not need to worry about that patient because she's a post-term patient and up to 100 is considered normal for them. That is why defining the risk is very important. About the variability, again, if it is between 5 to 25, then it is in the white category. Abnormal is less than 5 or more than 50 per minute, or pathological is more than 25 for more than 25 minutes. Accelerations, if they are present, it is reassuring. It is a good thing. If the accelerations are absent, but all the other features are normal, okay? So the variability is normal. There are no decelerations. Everything else, baseline rate is between 110 to 160. Then even if accelerations are not present, this is not considered a hypoxic CTG because this is a fetal sleep cycle. And this fetal sleep cycle lasts up to more than around 50 minutes. Some people say it is around 75, but by the RCOG, we will consider it as up to 50 minutes. So if all of the categories are normal, if all of the categories are in white zone, then it is a reassuring CTG. It is suspicious if there is one non-reassuring feature, and it is pathological if more than or equal to 1 abnormal or more than or equal to 2 non-reassuring features are present. Okay, so again, reiterating, and I think it will come again. So Dr. C. Bravado is very important and you should not miss it whenever you're assessing a CTG. Okay. So now the types of deceleration. So there can be early deceleration, which will be actually mirroring the contraction. Okay, so the contraction peak will be the decelerations base, the nadir of the deceleration. And this is considered benign. It is considered as head compression is happening. So we often see these in second stage, and these are considered non-worrisome. Variable decelerations are abrupt, and they vary in shape and timing, and they are caused due to cord compression. Late decelerations have the nadir, that is the bottom part of it, the trough, after the contraction has peaked. So the contraction has come, and after that, the deceleration starts. So the contraction's peak is coming first, and then the decelerations trough is coming. Okay. And this is worrisome because this is a sign of uteroplacental insufficiency or hypoxia. And in the last update, they have said late decelerations of any duration, okay, over any period are considered pathological. Okay, so this was the update in the most recent update on CTGs by NICE. And they have said that any late deceleration is pathological. Earlier, up to 30 minutes or 50 minutes, we were considering it as amber, but now it is all in the red zone. Prolonged decelerations are decelerations of more than or equal to 3 minutes. And how we manage them, we'll be coming to that. Now, what is shouldering? Shouldering is around a variable deceleration, and that is a reassuring sign, and loss of shouldering is concerning. So suppose this is your fetal heart rate, okay, and deceleration is going to come. So the baby's parasympathetic system recognizes that the contraction is coming and the heart rate is going to go down. So it has a little upslope, okay? It will go up a little bit, then come down, then come up, and then again overshoot a little bit, and then come back to normal. So this is known as shouldering of a CTG, and it is a very healthy sign. And these, if these are present, then it is actually reassuring, okay, that the baby's sympathetic system, parasympathetic system is responding normally. Now, if suppose the heart rate is going like this and it comes down, goes up, and then comes down, so there is no shouldering, absence of shouldering is pathological. Okay. Then if suppose the heart rate is going on, there's a little bit of a shoulder, then the heart rate comes down, and then it overshoots. Okay. If it happens like this, then this is also normal. So shouldering is just a little bit of rise of the fetal heart rate, maybe about 5 beats per minute. Okay. But overshooting is also considered abnormal. All right. Now, what is a sinusoidal pattern? Sinusoidal is a smooth undulating wave, and the variability is absent. We will come to this point again. What are the causes of a sinusoidal pattern? Fetal anemia or fetal severe hypoxia. So fetal anemia can happen if the mother has had a parvovirus infection early in pregnancy. So that can cause fetal anemia, or there has been some rhesus incompatibility, and the mother is immunized, sensitized, and the baby is getting the RH disease. So that will also cause sinusoidal pattern in the CTG. Now, acute bradycardia or prolonged deceleration, if it is there for more than 3 minutes, what are we going to do? Firstly, we are going to seek senior obstetric review. So you're going to call your consultant. At the same time, you're going to rule out an acute event. Acute event means a cord prolapse, an abruption, and a scar rupture. If all of these are absent, then you can wait for your consultant. If any of these are present, then you have to expedite the birth. Then you cannot wait. Okay, then you have to inform the consultant that this and this has happened, and I'm moving the patient to OT. What if none of these acute events are there, and there has been a prolonged deceleration? Then you're going to do some conservative measures. You're going to put the patient in left lateral position, give her IV fluids, and if the oxytocin group is on, of course, stop it. That is the first thing that we do. If this deceleration prolongs for more than or equal to 9 minutes, then you have to expedite the birth. You have to anyway keep the OT informed. And if there are no risk factors like the acute events, if you've not taken her to OT earlier, then you're going to shift her to OT now. If in between this time, so there has been a prolonged deceleration for 3 minutes, but it comes back to normal, let's say around 6 minutes or 7 minutes, then you're going to relook your decision. You're going to reassess your decision to expedite the birth, but of course, keep that patient under close observation. Now about fetal blood sampling, that is the pH of the fetus. This has also been removed in the latest NICE recommendation, and they have said that fetal blood sampling has not shown any kind of prognosticating factors, and in fact, it causes a little few complications. So they have removed this, but still, there has been a question a year back asking about the fetal blood pH. So we must know what are the basic cutoffs. So more than 7.25 is normal. 7.21 to 7.24 is considered borderline. So if it is borderline, then we will repeat the fetal blood sampling and continue the CTG in 30 minutes. And if it is less than or equal to 7.20, then it is considered abnormal and we have to expedite the delivery. So late decelerations are uteroplacental insufficiency, and sinusoidal pattern is a sign of fetal anemia, which can be due to any causes, but most commonly seen in parvovirus infection and rhesus incompatibility. Now, this is about the CTG physics. So CTG paper runs around 1 centimeter per minute. So in the UK, the paper runs, even in India, the paper runs 1 centimeter per minute, but in Netherlands, US, etc., there are some places where it is running at 3 centimeter per minute. So if the question comes in the exam, then your answer is going to be 1 centimeter per minute. And this is a very frequently asked SBA. So cardiotocography is not only recording the baby's heart rate, it is also recording the uterine activity. And the baby's heart rate can be measured bedside by Doppler ultrasound or by fetal scalp electrodes. And there is a tocodynamometer, which is attached to the maternal tummy, which is going to measure the uterine contractions. And any late decelerations, because this is a new update, so reiterating that, are classified strictly as red features. So like we said, if you can see the early decelerations, okay, they are coming and they are the peak of the contraction and the trough of the deceleration is corresponding. Okay, so this is known as an early deceleration. So basically they are mirroring each other. The contraction is mirroring the deceleration. This is a physiological sign of head compression and we do not consider it worrisome. These are variable decelerations. Of course, this is a schematic diagram, so we haven't shown any shouldering. Otherwise, shouldering is normally present in a normal variable decelerations. And they do not have any kind of relation with the contraction. They can come before, they can come at the time, they can come after, they can come anytime. Okay, even if the uterus is not contracting, they can come. So unless and until there are any concerning features, these variable decelerations are considered normal. They are considered in the white zone. Okay, so now late decelerations, the peak of the contraction is here. The deceleration has started here and the trough is after the contraction has passed away. Okay, so it starts after the contraction and the trough or the nadir of the deceleration is actually not peaking with the contraction. So this is a sign of uteroplacental insufficiency and this is a red feature. This is a pathological feature and you need to reconsider your whatever conservative measures you're using and all that, so that if these resolve, well and good. If they don't, then you have to take a fresh review. So normal CTG values we have discussed, baseline rate 110 to 160, variability 5 to 25 beats per minute. Acceleration is defined as more than a rise of more than or equal to 15 beats per minute lasting for more than or equal to 15 seconds and not more than 10 minutes. Okay, so the paper speed is 1 centimeter per minute in the UK. This is a very frequently asked question. Please do not go wrong in that. And the FBS values we have discussed, although the NICE has removed this categorization from its guidelines. Okay, right. So baseline is an average of the fetal heart rate over 10 minutes and the normal we have discussed is 110 to 160. Less than 100 is severe bradycardia. More than 180 is severe tachycardia. The variability, we've discussed 5 to 25 beats per minute is the beat to beat variation. And this is measured by the amplitude of the CTG in the CTG. And this is one of the most important signs of the fetal well-being. If it is reduced, that is less than 5 beats per minute for more than 50 minutes, then it could be a sleep cycle or hypoxia, or the patient may be sedated. Accelerations are reassuring. It implies that the CNS is intact. But like we said, absence of accelerations in the presence of all other normal features is also considered normal. Decelerations we have discussed early is head compression. It mirrors the contraction and it is physiological. Variable is a sign of cord compression. It is usually considered normal. And if it is 60 beats per minute for more than 60 seconds. If it is a late deceleration, then it is a sign of uteroplacental insufficiency. And this is a pathological sign. Fetal blood sampling, we are already discussed that. So now you are supposed to classify into normal, suspicious, or pathological. So white, amber, and red, depending upon whatever features you have noticed. Okay. Again, the mnemonic has been reiterated here because it is very important that you all remember it. Okay. So just as a recall of the CTG physics and fetal monitoring, normal heart rate is 110 to 160 beats per minute. Paper speed is 1 centimeter per minute. Normal variability is 5 to 25 beats per minute. Dr. C. Bravado, I'm not going to repeat it. Early deceleration is a sign of head compression. Late deceleration is a sign of uteroplacental insufficiency. It is a pathological feature. It has any duration, any number of late deceleration. If a late deceleration is present, it is pathological. Okay. Variable is a sign of cord compression. The concerning features are loss of shouldering. If it is the deceleration is taking more than 60 seconds or more than a minute to come back to its normal baseline, or if there is an overshoot coming to the baseline, okay, or there is a trough or a plateau at the base if it has come down. So that is a concerning feature. Reduced variability for more than 50 minutes is considered abnormal. Fetal blood sampling pH more than 7.25 is normal. Less than or equal to 7.20, you have to expedite birth. And acceleration is a rise in the fetal heart rate of more than or equal to 15 beats per minute, lasting more than or equal to 15 seconds. Okay, coming to hemoglobin electrophoresis and high performance liquid chromatography. Now, these are very interesting topics and a little confusing as well. There have been questions in the past where they've given you a picture of the electrophoresis or the HPLC and asked you to kind of tell us what is the abnormality. So we will go through it. And I'm sure after this, you should not have a problem. So normal adult hemoglobin fractions, as we know, are HbA, which is the maximum, 95 to 98%. HbA2 is 2 to 3.5%, and the fetal hemoglobin is around 0.8 to 2% in a normal human being, normal adult human being. So if there is microcytic anemia, then we are supposed to distinguish iron deficiency anemia and thalassemia. And how do we do that? Then we go on to the next value called the mean corpuscular hemoglobin. If that value is more than 27 picograms, then it is more likely to be an iron deficiency anemia. If, however, it is less than 27 picogram, then it is beta thalassemia trait. Now, if you've come to a conclusion that this is something related to beta thalassemia, how are we going to determine it? Then we can do electrophoresis or HPLC, and we prefer HPLC because that is more diagnostic, that is more accurate. And in the HPLC, if the level of HbA2 is more than 3.5%, okay, this value is important, then that is diagnostic of beta thalassemia trait. Iron deficiency, then you go on further to measure the ferritin. The HPLC, of course, if you do it, it will come out to be normal. In thalassemia, the ferritin may be normal or high, and there will be abnormal HPLC. Now, how do we recognize the pattern? So the thalassemia trait, we told you, the HbA2 will be raised beyond 3.5%, and there might be some increase in the fetal hemoglobin fraction as well, okay? And there will be microcytic anemia on the peripheral blood picture. Sickle cell trait, there will be two peaks. There will be an HbA peak and an HbS peak. I will come to this and we will discuss it. Sickle cell disease is HbS will be predominant and there will be no hemoglobin adult. Okay, macrocytosis, of course, it is macrocytosis. So the MCV will be increased. It is the most common cause is B12 or folate deficiency or alcoholic liver disease. HbF fraction or the fetal hemoglobin fraction is measured by alkali denaturation. This is also an SPA, okay, and which is done by the BETK method. HbA2 is measured by capillary electrophoresis or HPLC, and antenatal hemoglobinopathy screening is offered in high prevalence areas. So in areas where thalassemia is prevalent, like the Mediterranean region, over there antenatal screening is offered. Okay, so the key MCH more than 27 is iron deficiency anemia, and less than 27 and HbA2 more than 3.5 is a sign of beta thalassemia trait. All right. So if I say that the HbA is this peak, okay, and the HbA2 is here, and then we give you that the HbA2 is 3.8%. So what is this? When we have given you that it is more than 3.5, this is a beta thalassemia trait. Okay, now we say that the HbA2 is high, okay. The HbF is also there. There is no, or HbF is peaking, okay. And the HbA fraction is there or it is negligible. Okay, what does this picture show? This is a sign of beta thalassemia major. Okay, so this is beta thalassemia major where the fetal fraction is more, HbA2 is also more, and HbA is negligible or absent. Okay, moving on to the next one. Suppose we say that the HbA fraction is this and the HbS fraction is also this. So these are two peaks showing in the sickle cell range and the adult hemoglobin range. Okay, so what does this mean? So this is sickle cell trait. Why is this not disease? Because in disease, there will be negligible or absent adult hemoglobin, okay, and there will be a single peak of HbS, okay, with other fractions little, all right. So a single peak will be present in sickle cell disease, all right. So I hope if these questions come, then you are able to answer them confidently, okay. They will usually give you HbA2 level is more than 3.5 or whatever. Okay, they will give you a hint to go towards beta thalassemia trait. And then you have to see which fraction is present, which is not present, and accordingly answer the question. Okay, so this is a trace where all the fractions are mentioned. So normally it is like first adult and then sickle cell. So first HbF, so from the left to right, it is first HbF, then adult, then and so HbA2, sickle cell. So these are the kind of the most prominent peaks that we are supposed to look for, okay? So from the left to right, it is first adult and sickle cell, okay? So this is kind of a mnemonic. Then this is HPLC, okay? And this is electrophoresis. Now in electrophoresis, you will be given slides, okay? And in slides, it means that it is actually, of course, it's electrophoresis. So it is checking the charge which is present on the hemoglobin. And the adult fraction is the most. So this is origin is the negative pole. And then this is the anode or the positive pole. So HbA is the most negative. The adult hemoglobin is the most negative. That is why it will move fastest and come to the last area or the closest to the anode area, the positive zone. So what was the mnemonic for this? A fat Santa Claus, okay? So A, F, and sickle cell comes in between, and then HPC, HPA2, HPE, and there's something called HPO. They are all going to move along with HPA2. Okay, so this is the zone for HBC, HPA2, HBE, HPC. So a fat Santa Claus, okay, a fat Santa Claus. So Santa Claus is C, but C moves with A2. Okay, so if it is a normal pattern, then you will see a thick zone in adult area and the others will be minor. If it is a beta thalassemia trait, so we had seen in the slide, okay, in the graph, in the peaks, that there was HbA2 and there was adult hemoglobin. And again, you can see that the HbA2 is quite significant, more than the normal category. In beta thalassemia major, there is no adult hemoglobin, okay? There is a major fraction of HbF, and beta thalassemia major also has HbA2 in a significant quantity. Talking about sickle cell trait, we said that there was an adult hemoglobin fraction present and a little bit of sickle cell fraction also. So this is sickle cell trait. And what is the difference between sickle cell trait and disease or anemia? In anemia, there is no adult fraction and there is a big amount of sickle cell hemoglobin. Okay, so this is between the HPLC and electrophoresis. If they give you a slide or if they give you a graph, then you should be able to know which fraction of the hemoglobin is present and accordingly answer. Okay. So now moving on to a few biochem and imbalanced electrolytes, if they give you. So this is also clinical management. There's actually a lot of overlap between data interpretation and clinical management and physiology as well. So let's discuss the key points. If the patient has come with prolonged vomiting or hyperemesis gravidarum, then is losing potassium, she's losing gastric contents, and the classic pattern, okay? So this is where we go wrong. So when we say the potassium is going out, we feel if it is hypokalemia, it will be hypernatremia, but it is not so. In hyperemesis gravidarum, the GTT says that the classic pattern is low sodium, low potassium, and low urea. So hypokalemia is present because the potassium is lost in the vomitus, in the gastric contents. Then because of dehydration and poor intake and because of water retention, there is hyponatremia. And because again of poor intake, there is no protein and poor production, the urea is also low. Okay, so low sodium, low potassium, and low urea. Okay, so this is something peculiar about hyperemesis patients. And there is hypocholoremic metabolic alkalosis. Okay, so they can just give you this question: a patient has come with hyperemesis gravidarum, what is the ABG likely to show? So it is going to show metabolic alkalosis. And of course, if they've given hypocholoremic, then hypocholoremic metabolic alkalosis. Now, this patient of hyperemesis is poorly nourished. She's lost all her nutrients. She's severely protein deficient. And now you start refeeding her. Okay, so now refeeding also is a risk. Okay, as when you start refeeding, the body is not able to adjust with the intake. And this is what causes the refeeding syndrome. And the hallmark of this refeeding syndrome is hypophosphatemia. Okay, so there is a catabolic state of hyperemesis. Now it is going to shift to the anabolic state, and that will drive the phosphate, potassium, and magnesium into the cell. Okay, and when they move into the cell, this causes hypophosphatemia, hypokalemia, hypomagnesemia as well. Okay, so you have to monitor the electrolytes and give thiamine before or with refeeding nutrients that you're giving back. So give the patient thiamine. All right, AG in pregnancy, if you do, then the normal pregnancy ABG, I think we'll be discussing that tomorrow, is going to be a compensated respiratory alkalosis, and that is normal. Okay, so the values we will be discussing tomorrow. Bile acids, as far as intrahepatic cholestasis is concerned, it is mild, moderate, and severe. So the diagnostic cutoff is 19 micromoles per liter, and between 19 to 40 or 39, it is considered as mild, and between 40 to 99, it is considered as moderate, and more than or equal to 100 is considered a severe form, and this is more than or equal to 100 micromoles per liter of bile acids is a sign that the fetus can have a stillbirth. Okay, so till 100, the risk is as much as the background population, as much as the patient who doesn't have intrahepatic cholestasis. But once it crosses 100, then the risk increases, and then you consider the patient to be delivered by 35 to 36 weeks. Okay, if it is between 40 to 99, then the background risk is as much as the stillbirth risk is as much as the background population, but it increases after 38 to 39 weeks. So if the levels are more than 40 and up to 99, you will plan their delivery between 38 to 39 weeks. But less than 40 and more than 19, they are taken to term. So that is considered a normal thing. Okay, the risk of stillbirth is as much as the background population, so you do not have to plan an early delivery. So vomiting in pregnancy causes low sodium, low potassium, and low urea. And the hallmark of refeeding syndrome is hypophosphatemia. Okay, moving on to imaging, ECG, and urodynamic interpretation. These are certain important numbers that you are supposed to remember. And of course, these are important in our clinical practice as well. So the speed of an ECG paper, speed of CTG was 1 centimeter per minute. Speed of ECG paper is 25 millimeters per second, and each small square is 0.04 seconds, and each large square is 0.20 seconds. Now, how do ovarian cysts look on ultrasound? There can be many kinds of cysts. So the simplest cyst or the follicular cyst is unilocular, thin-walled, anechoic, and there will be posterior wall enhancement. And these usually resolve in up to 6 weeks, and they are rarely more than or equal to 8 to 10 centimeters. Hemorrhagic cyst has a cobweb appearance, okay, and or a fishnet reticular pattern because of the fibrin strands of the blood which is going to clot inside. Then there is something called as posterior acoustic enhancement. If the beam is flowing through an anechoic fluid window, then if there is a cyst that is seen at the end of the structure, then there will be enhancement. So there will be a bright hyperluminescent light at the end. So that is known as posterior acoustic enhancement. The placenta is normally fundal, okay, but it could be low-lying and previa, which is covering the os, and it could be accreta, okay. So placenta accreta is when it is actually invading the myometrium, and the accreta spectrum has increta and percreta. Increta is when it is invading the myometrium more than 50%, and percreta is when it is perforating the myometrium, perforating the myometrium and actually invading the surrounding organs. Okay, so that is the placenta accreta spectrum. About urodynamics, it has been asked. Yes, urodynamics have been asked in the past. So very basic things you need to know. So first is, what are the channels that we use? So we are measuring 3 main pressures. So the pressure in the abdomen, okay, then the pressure in the vesicle or the bladder, and the detrusor muscle pressure. So how do we deduce the detrusor muscle pressure? We subtract the abdominal pressure from the vesicle pressure. Then if there is detrusor overactivity, which means that the detrusor is just acting on its whim. Okay, the detrusor, I mean, there's no trigger, nothing, but the detrusor is just contracting. Okay, and with or without a leak, we will come to that. Okay, and then there is stress incontinence, where a patient is coughing or she's being made to do Valsalva, and there is increase in the abdominal pressure, and there is no detrusor contraction, but the P abdomen and the P vest will rise, and there will be a leak. Okay, urgency, frequency, and nocturia with no stress leak is a sign of detrusor overactivity. Okay, so if a patient has come to you with urgency and she's saying, I'm going to the bathroom a lot of times and I have to wake up in the night a lot of times, but when I'm coughing, no, I'm not leaking. Okay, so that is a particular symptomatology of detrusor overactivity. Now, in ultrasound, certain characteristic features. So, snowstorm appearance, molar pregnancy. We all are very well versed with that. We've done a lot of questions on that. If suppose a patient has presented with a pain abdomen, she's pregnant, and she has a woody hard uterus. Okay, they mentioned that she has a woody hard uterus on clinical examination, and the ultrasound shows a concealed retroplacental clot, then this is a sign of abruption. So what are the important points here? Each small square of the ECG measures 0.04 seconds, and there is posterior wall enhancement in a simple cyst because of the acoustic anechoic nature of the cyst, and the detrusor pressure will rise on filling, and that is a sign of detrusor overactivity. Okay, so let's discuss this. They can give you in any order. It's not necessarily abdomen is first and then vesicle and detrusor. It could be detrusor first. So you need to first see what the graph is showing, which is what. Okay. Then suppose it is showing that there is some amount of activity here, and then the patient does a Valsalva, so the pressure rises. And of course, if the patient is doing Valsalva, it will be transmitted to the bladder, but the detrusor is normal. Okay, so this particular sign, okay, where the abdomen pressure is made to rise and the vesicle P-Ves is also rising, but the detrusor pressure stays normal. Okay, so P-Ves minus P-abdomen, it is negligible, it is 0. So this is normal. So this is a normal pattern. Okay, this is a normal patient who doesn't have any kind of detrusor overactivity or incontinence or anything. Now, if we say that this pressure has, increased here, and this pressure has increased, of course, here also, this is normal, but the graph says like this, either an arrow or a drop or something like that, then it means that the patient is leaking, or they will mention leak over here. Okay, so these are the features that you're going to look out for. So what is this? This is a sign of SUI, okay, or urodynamic stress incontinence. Okay, so because it has been normally for stress urinary incontinence, we do not do urodynamic study. But if you've done it and if it has shown this, then it is an SUI. Now, if suppose the next graph we go to, the abdominal pressure is normal, it's like normal breathing pattern, okay, and then the detrusor over here is trying to act funny. There's obviously the normal filling is happening, and the detrusor wants to, act, and then again it goes up, and over here also the vesical pressure obviously will be transmitted to it, but there is no leak. Okay, no leak. If there is no leak, then this is detrusor overactivity or overactive bladder dry. Okay, in this case there is no leak. However, if they show that there is a leak over here, okay, if they show that the leak, they can show either an arrow or a drop. They will not show both, or they will mention it here. If there is a leak, then this is overactive bladder wet. Okay, so if they've given you a classification of overactive bladder dry or wet, then go in for that. Otherwise, this is detrusor overactivity with incontinence or detrusor overactivity without incontinence. So this is a very simplified explanation of the urodynamic graph. And in part 1, this is what is needed. And then, of course, in the voiding pattern, then it will be a normal, kind of a sine wave, and the abdominal pressure will be normal. So this is normal voiding. Okay, so this is in brief about the urodynamic graph. You really do not need to know more than this for your part 1. There will be complicated graphs given in part 2. Okay, but for now, this is enough. All right, let's do some high yield questions. So these are actual questions which have come in the previous papers. The term CTG shows baseline of 130 beats per minute There is a variability of 10 to 15 beats per minute. There are no decelerations and no accelerations over 20 minutes. So what is the most appropriate interpretation of the CTG? So because there are absent accelerations, it is a compromised CTG. You should do conservative measures, reposition the mother, give her IV fluids, and repeat the CTG in 30 minutes. Option B is accelerations are mandatory. So if this patient wants an epidural, you should not give it. Option C is the trace is abnormal, so you have to intervene immediately. Option D is this is a likely fetal sleep cycle. This is not acidosis and it is safe to proceed. Or option E is chronic hypoxia from uteroplacental insufficiency. So you can give the answers in the chat box if you want, and I'll move to the answer right away. So this is a likely fetal sleep cycle, and this is not acidosis. Okay, so it is safe to proceed because the baseline and variability are normal. The absent accelerations, but otherwise all features are normal. So this is considered a normal fetal sleep cycle. Okay, next question. Labor CTG shows a smooth, regular, undulating waveform with absent variability. The woman has a febrile illness with rash early in pregnancy. So what is the best description of this particular CTG? Is it normal? Is it reassuring? Is it acute bradycardia? Is it sinusoidal or fetal tachycardia? So I think we've discussed this, and this is going to be a sinusoidal CTG. Okay, so this is the pattern of a sinusoidal CTG. It is smooth, undulating. Okay, and it is seen in most commonly in fetal anemia and patients with suspected parvovirus B19 or RHD or chronic hypoxia. They will show this particular pattern. 25-year-old fails to respond to oral iron. The hemoglobin electrophoresis, okay, electrophoresis is given here. HB adult is 94.1. The HbA2 is 5.3%, and fetal hemoglobin is 0.6. So what is the most likely cause of anemia? Is it iron deficiency? Is it sickle cell disease? Is it beta thalassemia trait? Is it beta thalassemia major, or is it alpha thalassemia? So go ahead and answer in the chat box, and they can either give you this kind of a descriptive thing, or they can give you an image in which they will mention that there are two peaks, one of major thing. The major peak will be adult hemoglobin, and then there will be a peak of A2. Okay, and then they will give you values in which the A2 value has been given as 5.3. So the answer over here is beta thalassemia trait, because we know that anything above 3.5 is considered as beta thalassemia trait. Why is this not beta thalassemia major? Because adult hemoglobin fraction is the major one. It is not the fetal hemoglobin. Okay, so that is why this is not beta thalassemia major. Okay. Protracted severe nausea and vomiting in pregnancy. Which biochemical pattern is most likely between sodium, potassium, and urea? It is going to be either high, 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 or it is low, 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 or it is high, low, low, or it is low, low, high, or low, high, high. And I'm sure nobody is going to get this wrong. So this is going to be low sodium, low potassium, and low urea. Okay, so particularly in hyperemesis gravidarum, because of prolonged vomiting, there is hypokalemia. Because of dehydration and water retention, there is hyponatremia, and because of poor intake, there is low urea. Okay, so okay. A woman admitted with hyperemesis gravidarum is improving and refeeding begins. So you started to give her refeeding, started to refeed her with proteins and IV fluids, etc. Which finding identifies the refeeding syndrome? Is it hyperkalemia, hypernatremia, hypercholeremia, hyperglycemia, or hypophosphatemia? So, of course, we know that it is hypophosphatemia, okay, but also there will be hypokalemia, hypomagnesemia. So over here, of course, the hallmark is hypophosphatemia, and there will be low potassium and magnesium. On a standard ECG recorded at 25 millimeter per second, which is the normal paper speed of an ECG paper, how much time does each small square represent? So each small square is 1 millimeter. So let's see. So this is your ECG paper. It moves at around 25 millimeters per second. Now let us focus on this small square. So this small square has 5 small squares in itself, and each small square is around 1 millimeter. Okay, so the entire box is around 25 millimeter, 5 millimeter each. Okay, because it is 5 small squares. So 5 such squares will be 25 millimeter, and we are moving 25 millimeter per second. Okay, so 1 millimeter is one small. So it is 5 into 0.04 seconds or 0.2 seconds. Okay, so we must know this even in clinical, but it is important for the exam also. Measurement of the small square and the big square has been asked. ECG paper speed has been asked. So these are certain important points. So the answer of the small square measurement was 0.04 second. All right, moving on to some biophysics. I think we're much in time. So biophysics, we'll be discussing some imaging, monitoring, and energy topics. And the important topics sound MRI principles and safety, where I think a lot of us get confused because we refer to the radiologists and they give up their information. And we just kind of read it. But it is important now for your MRCOG exams, part 1, part 2, and part 3, to understand what is T1 and T2. Not basically the physics behind it, in brief about the physics as well, but the images. CT physics and fetal monitoring, we've discussed, so I've moved this from level to the other one. Okay, radiation immunancy, lasers in gynecology, and diathermy and electrosurgery, which we are using day in and day out, and we need to know a little bit in detail about it. Okay, so ultrasound physics is a very important topic. Okay, it is considered a hot topic, and the ultrasound sound wave 20 kilohertz. So this particular range of sound is inaudible. And in ultrasound, what is the diagnostic frequency range? We use 2 to 20 megahertz. Okay, so please, even in this and in diathermy and electrosurgery, please remember the units. Okay, so in ultrasound, it is 2 to 20 megahertz. These are crystals which are present in the transducer. This was a question I most recent exam. Then if the probe has higher frequency will equate to better resolution but less penetration. Okay, so it is going to give you great images, but it is not going to give you images of the deeper structure. So in a weak space, supposed to use a curvilinear or a probe with lower frequency, which will give you better penetration. But of course, the downside is that gives lower resolution. So abdominal probes, the frequency is between 2 to 5 megahertz. It measures up to the deeper structures. Trans frequency than that. It gives higher resolution images of the organs that it is going to be examining, and the frequency is 5 to 9 megahertz. So mostly it is 5 to 7, but nowadays up to 9 megahertz has come, and that is why there have been a change in a few guidelines like Rotterdam's criteria, etc. Because high frequency very minutely. So even a normal shows this. So this is why the criteria is changed a little bit, but that is for a later date. So linear probe has it is going to measure for the smaller parts, okay, like the thyroid, and for the superficial structures. So the frequency is 7.5 to 15 megahertz. Tissue, okay, in a soft tissue or tissue is 40 meters per second, and this is assumed as a constant, and this is a SPA. Okay, acoustic impedance mismatch creates echoes. Okay, so if there is acoustic impedance when the wave is traveling, then there will be production of echoes. So this is a schematic diagram showing the frequency of the ultrasound probes. It can be between 2 to 20 megahertz. If it is a low frequency probe, then the depth of penetration is more and the penetration is lower if it is a high frequency probe. So the penetration is reducing as the frequency is increasing. Image resolution for low frequency is low and it is higher for higher frequency. Okay. Now the abdominal probe is curvilinear, 2 to 5 megahertz. It will target the deeper structures and it is used in obstetric scans as well. The resolution is lower. Okay. And the penetration is around 25 centimeter. In a transvaginal probe, the frequency is 5 to 9 megahertz. These are all frequently asked questions. They can ask you frequency of the abdominal probe, the transvaginal probe. Okay. So 5 to 9 megahertz. It is mainly for the pelvic organs. It's a very good tool for early pregnancy. It has a high resolution and penetration is around 8 centimeters. In a linear probe, it is usually used for smaller parts or superficial areas and like the breast and the thyroid, etc. Okay, the frequency 0.5 to 15 megahertz. So breast and thyroid, it is only going to measure superficially. It has the highest resolution and the penetration is around 4 centimeters. Now, there is, we have another slide on that, but I'll just touch upon this here also. There's safety index. So although we say that the ultrasounds are very safe, but still there is a principle of as low as reasonably allowed. Okay, so ALARA principle is there, in which we have to keep the thermal index and the mechanical index in a particular category. Okay, so the mechanical index should not be more than 1.9. So it should be kept to less than 1.9. Otherwise, there can be cavitation, which can happen. And the thermal index has to be less than 0.7, which is particularly important for OBS ultrasound. Okay. Okay. So about the modes, now there is in the past, we were using something called as the A mode, which is the amplitude mode. That never used to give any images. It only used to tell us, okay, it used to just give us 1D measurements, so just lines. Okay, so the organ is like this deep and you are supposed to understand what it means. So now this is only used for measuring the eye measurements. So it's more or less obsolete in the other areas, okay, but it is still used in the eye measurements. So B mode is for brightness and it gives you a 2D grayscale image. M mode is of course for motion. M is for motion. You measure the fetal heart or the heart also, adult heart also in M mode. Then Doppler is motion detection via frequency shift. Okay, so Doppler principle is that the frequency shift is proportional to the blood velocity. The angle of insonation, how you keep your probe, is also important. That is because of the cosine effect. Continuous wave is put. Okay, it is got high velocity and there is no information on the depth. Pulsed wave, if suppose you're giving a normal Doppler, then it is not going to give you depth information, but a pulsed wave Doppler will give you information even on the depth. So that is the difference between a normal Doppler and a pulsed wave Doppler. And in color Doppler, it is going to give you a direction. So direction is the mnemonic is blue away and red towards. So what do you mean blue away and red towards? Towards the transducer. Okay, so if you put the transducer and you are seeing a red blood vessel, that means the blood is coming towards the transducer. If it is blue, then it is moving away from the transducer. Okay, so that is the mnemonic BART, B-A-R-T, blue away, red towards the transducer. Just remember the complete thing. Okay, so frequency versus depth. If the higher frequency probes are there, the images are better resolved, so they are sharper, but the depth is limited. Okay, if it is a lower frequency, then the depth is better, but the images have low resolution or they are blurred. Okay, so just a recall. So diagnostic ultrasound frequency 2 to 20 megahertz. We use piezoelectric crystals in the transducer. This is important. Higher frequency gives better resolution but less penetration. Transvaginal probe, this is also important. The frequency is 5 to 9 megahertz. Abdominal is 2 to 5 megahertz. The velocity in tissue is 1540 meters per second. Then the B mode is for brightness or 2D image. Doppler is, the principle is on the frequency shift and it measures the velocity. The mechanical index and the thermal index, the points are very important. So if suppose the mechanical index goes beyond 1.9, then what is the risk? The risk is of cavitation. So, and if it is a thermal index, then you're supposed to keep it less than 0.7. Okay, then of course, Alara principle we've discussed. Okay, so this is about the propagation of speed of the propagation of speed of ultrasound. So there has been a question in the past which has asked which of the following has the least, kind of speed. Ultrasound waves flow the least in one of these structures. So unless air is mentioned, where the speed is the lowest, the next was fat. Okay, so in that question, the answer was adipose tissue. Okay, so this is about the relative speed. The maximum is in bones. So if the structure has increased stiffness and reduced density, then the propagation of sound is higher in those tissues. Okay, moving on to MRI principles. So magnetic resonance imaging, it uses strong magnetic fields and radio frequency pulses. So the principle is that once you're giving these radio frequency pulses, it is these hydrogen nuclei or protons which will align in the magnetic field, and depending upon what speed they come back into the alignment in, you have T1 and T2 images. Okay, so the radio frequency pulse will tip the protons, tip or agitate them, and once they are moving and then once they come back into their alignment, the relaxation of these protons will produce signals. It is very important to know that one, they are protons, and then they are hydrogen nuclei, because this question has also been asked. The field strength is measured in Tesla. Now, clinically, or most of the MRI machines have around 1.5 up to 3 Tesla, but in research areas, they are using up to 7 Tesla, okay? But the most common is 1.5 and up to 3 Teslas. So what are T1 weighted images and what are T2 weighted images? In T1, the fat will appear bright, okay? It will give a high signal, it will appear bright. The water appears dark. So water can be urine or it can be the CSF, any kind of fluid. It will appear dark. And these images are best used for studying the anatomy of a particular organ or a particular area. T2 weighted images, water or CSF will appear bright, and even the fat appears a little bit bright. But if you compare it with the T1, then it is not as bright as that, okay? And mainly the difference is that the water and CSF will appear bright, and this is particularly for pathological lesions like edema, inflammation, or any lesions which are present. Now, T2 weighted images can also be modified, okay? T2 modified images can have flare or stir images, FLAIR or STIR images, which are fluid attenuated inverse images, okay, in which, so normally what happens in T2 is that the CSF is bright, but if you modify it to flare, then the CSF image is suppressed, okay? So why is this important? Because if the CSF is suppressed, then the areas around it, okay, if there are lesions or edema or inflammation around it, around the ventricles, around the spinal cord, they will appear bright, okay? Otherwise, the edema is also bright, CSF is also bright. So how do we make out what is the difference? So we modify the T2 and we suppress the CSF. Then there are short 2IR images or the STIR images in which the fat is suppressed. Okay, so normally the fat is like intermediate. So in this, the fat will be suppressed again to diagnose various lesions. So MRI in pregnancy, it is safe because it does not use any ionizing radiation. Gadolinium contrast is supposed to cross the placenta. It has a prolonged retention time, and that is why we must avoid gadolinium as much as possible. But the latest guidelines also say, the radiological guidelines also say that if, again, benefit and risk ratio we have to do, if suppose the patient needs gadolinium, you can get, if it is like a life-saving procedure or something, then you can even use gadolinium. So in those cases, even in pregnancy, gadolinium is permitted. Okay, sedation is really needed for MRI. It is very useful for placenta creta spectrum, fetal CNS anomalies, and deep endometriosis. What are the contraindications for MRI? If the patient has older models of cardiac pacemaker, if they have ferromagnetic aneurysm clips, if they have any cochlear implants, if they have metallic intraocular foreign bodies. But most modern surgical clips, IUDs, they are MRI safe. Okay, so you can, even the heart valves, if they are replaced, so if they are biological valves, then the patient can go in the MRI machine safely. All right. So we discussed that in T1 weighted images, the fat appears bright, okay, and the water appears dark. So in this image, okay, what do you see? That B is the bladder. So the urine is appearing dark, okay. And so A and C, what are these? These are T1. And in the B and D images, you can see the bladder is filled with urine and that is appearing bright. So water is bright. And so this is a T2 image. So that is how you differentiate between T1 and a T2 image. Okay. So the mnemonic is water is too bright. So two is a play of words, TWO. So T2, water is bright. Okay. And in T1, the water is dark. Fat is very bright in T1, but in T2 also it is bright, but lesser amount. Okay. Talking about the flare images. So this is a T2 image of a spine where you can see the CSF is bright. Okay. Now, if you see in this particular image, the CSF is made to be dark. Okay. So this is a flare image. Okay. Where the CSF is suppressed. And even in this, the fat is also suppressed. So if you can see, this is the fat layer. Okay. Or in the stir images, the fat is also suppressed. So this is only for your clinical information. I'm not sure whether these kind of questions are asked, but nowadays they are advancing a little bit. So they are a lot into ABG, and now they advance the level one step more. We'll be discussing that again tomorrow. Okay, so you should know all of these facts. So MRI principles and safety, the recall is that MRI uses magnetic field plus radio frequency. There is no radiation involved, so it is considered safe in pregnancy. T1, fat is bright and water is dark. It is used for anatomy. Okay, in T2, the water is bright and it is used to study the pathology in a particular area. Okay, the strength of the MRI magnetic field is measured in Tesla, and it is basically 1.5 T most commonly, and clinically 1.5 to 3 Teslas. Okay, flare suppresses CSF. MRI is safe in pregnancy. You should avoid gadolinium in pregnancy. Contraindications are pacemakers and aneurysm clips. Modern IUCDs are MRI safe, and MRI is best for placenta creta and endometriosis depth. But what is the first line investigation for placenta creta? It is TVS. Okay. If in the TVS you're not able to make out what grade of placenta creta it is, whether it is in creta or per creta, you're not, if it is indeterminate, then you move on to the MRI. The first line will remain ultrasound. Okay. Radiation in pregnancy. So ionizing radiation, the imaging forms are X-ray, CT scan, fluoroscopy, and nuclear medicine. The units are very important. And gray is the unit which is for the absorbed dose. And 1 gray is equal to 1 joules per kg. Okay, sievert is a unit for equivalent dose, and that is the amount of absorbed dose into the tissue factor. And Roentgen is an older unit of the absorbed dose only. So the doses per common procedure and the approximate fetal dose in a normal chest X-ray. So you're doing a posterior anterior chest X-ray. The radiation which is transmitted to the baby is less than 0.01 milligrays, which is negligible. So therefore, if a chest X-ray is done in pregnancy, it is not teratogenic. It is not going to cause any harm to the fetus. Abdominal X-ray is around 1 to 3 milligrays. Pelvic CT is 25 to 50 milligrays. Abdominal CT is around 8 to 25 milligrays. VQ scan. Okay. Now, these two are very important because if they give you an image of a picture, clinical scenario of pulmonary embolism, and they ask you, the chest X-ray is normal, the DVT investigations are going on. So if a VQ scan is done, then what is the fetal radiation, expected? Then it is 0.1 milligrays. Okay, so the NICE guideline says 0.1. We have said 0.1 to 0.5 milligrays, and CTPA is around 0.5 milligrays. Okay, so it is. I think I'm sorry. I'm getting confused. VQ scan is 0.1 to 0.5. We usually take it as 0.5, and CTPA is lower. Okay, it is 0.01 to 0.66 milligrays. Okay, it is a lower fetal dose than VQ scan for pulmonary embolism workup. So CTPA is around 0.1. Okay, we take it as 0.1, and VQ scan we take it as 0.5. Okay, that is what is mentioned in the NICE guidelines. Now, a little bit about the fetal risk thresholds. So if the radiation exposure is there, so there is a nice table which is given in the talk, but that's again not really of that much significance to you. What you need to know is any radiation exposure less than 50 milligrays. Okay, there is no increased risk of anomalies. Okay, in between 50 to 100, it is uncertain, so it is considered usually safe. If it is more than 100, okay, or 10 rads, then there is a risk of teratogenicity or growth restriction. And if the radiation dose exposed, the fetus is exposed to more than 50 milligrays, then there is a risk of gross malformations and microcephaly. Okay, so less than 50 to 100 is uncertain. More than 100 is a risk of teratogenicity, and more than 500 is gross malformations. Critical periods. So if the embryogenesis is happening, then week 0 to 2 is all or nothing. All or nothing means either the baby is not going to be affected at all by that radiation, or the baby is going to miscarry. Okay, so it is all or nothing in between week 0 to week 2. The most sensitive period for most of the organs is week 3 to 8, where the majority of the organs are developing. I studied in the embryology chapter. Okay, so this is the time when if a baby is exposed to radiation, there's a high risk for malformations. Between week 8 to 15, the CNS is developing. So if the radiation dose is received by the baby, there is a risk of microcephaly. Between week 16 to 25, the brain, the CNS is continuously developing. So there can be growth restriction and some neurological problems as well. And more than 25 weeks, the tissues are now relatively radioresistant, and only very rarely will the fetus be affected. Now, background radiation risk is around 2.4 millisieverts per year. This is a natural background risk. So even if we are not undergoing any kind of radiation, we are receiving 2.4 millisieverts per year. This is about the UK. Okay. Cumulative cancer risk is approximately 1 in 17,000 per 10 milligray fetal dose. Okay, so this is about the fetus, about the baby. Cumulative cancer risk is 1 in 17,000 per 10 milligray of radiation exposure received. MRI is safe alternative. It doesn't have any ionizing radiation. So 50 milligrays, below 50 milligray fetal dose, there is no increased anomaly, and above 50 milligray, it is supposed to be teratogenic. Okay, so gray is the absorbed dose and sievert is the equivalent dose. 1 rad is equivalent to 0.01 grays. Chest X-ray fetal dose is 0.01 milligrays or negligible. And as far as the background risk or natural background risk is concerned, it is equivalent to 3 days of receiving background radiation. Pelvic CT is around 25 to 50 milligrays. If it is less than 50 milligray exposure to the fetus, there is no increased risk, and more than 100 milligrays is teratogenic. Critical period is the time when the organs are developing, most of the organs are developing in the fetus, in the baby, and that is between week 3 to 8. CTPA, I'm sorry for the earlier confusion, CTPA has lower exposure as far as the fetal dose is concerned over the VQ in pregnancy. CTPA dose is around 0.1, VQ is around 0.5. Okay, so that is the dose which the radiations will give to the fetus, developing fetus. MRI is considered safe, and the background radiation that we receive is around 2.4 millisieverts per year. About lasers, which are very frequently used in practice nowadays. So what does it stand for? Light amplification by stimulated emission of radiation. And these are monochromatic, coherent, high intensity waves. And once they reach the tissue, so they can be absorbed, then they produce heat and vaporization and coagulation. Okay, and depends upon the wavelength and the tissue chromophore. Chromophore is which tissue is absorbing which laser color. Okay, so CO2 laser is got the longest wavelength. It is 10,600 nanometers. It is absorbed by water. So the chromophore for CO2 laser is water. It causes only surface ablation, only up to 0.1 millimeter depth. The uses are in vulval intraepithelial neoplasia, condylomata, and cervical or SIN ablation. So the CO2 laser itself is invisible, and you have to use something called as the helium neon red aiming beam to actually target the tissue. And then wherever the target is there, then you will focus the CO2 beam over there and then do your procedures. Then you have the ND-YAG laser, which is around 1064 nanometers. It has a depth of 3 to 5 millimeters, and it is delivered through a fiber optic system. It is used for endometrial ablation and tumor debulking. So KTP laser is 532 nanometers, and it has a green light absorbed by hemoglobin, excellent hemostasis, used in vascular lesions like condylomata and endometriosis. Then the argon laser is a little lower wavelength. It is around 488 to 514 nanometers. It is used in retinal procedures and in dermatology. Diode lasers are semiconductors, and they are very versatile. And there is something called as holmium laser, which is also a YAG laser. The wavelength is around 2100 nanometers, and it is used in lithotripsy. Now, as far as safety is concerned, the lasers are divided into 4 categories, and it is the class 4, which is used in medical practice, and that also has the highest risk. So you have to use a protective eyewear, okay, which is mandatory when you're using lasers. Reflective surfaces are hazardous, and the smoke which is generated when you're using laser, it has to be evacuated. So if you're doing a LEEP or a LEDS procedure, for example, for SIN lesion, then the apparatus should have a smoke evacuation attached to it, okay? Because the laser which will produce the smoke that is produced by the laser can be HPV DNA. Okay, so that is why the smoke needs to be evacuated and using a protective gear. So there is a designated laser safety officer, and fire risk is there in oxygen enriched environments. So chromophore for CO2 is water. For KTP lasers is hemoglobin, and for ND-YAG laser is deep ND-YAG laser, ND-YAG laser has deeper penetration, okay? So wavelength we have discussed is 10,600 nanometers for CO2. For KTP, it is 532 nanometers, and ND-YAG laser is 1,064 nanometers. The chromophore for CO2 is water. Chromophore for KTP is hemoglobin, and the chromophore for ND-YAG is protein. So these are its uses. It is used, the CO2 laser is what we use for WIN, for CIN, for condyloma acuminator, and for skin resurfacing, okay? And it is invisible, so you need a visible aiming beam to use the CO2 laser. The depth of penetration is only 0.1 millimeters. In KTP laser, it is 1 to 2 millimeter. And in gynecological procedures, it is used in vulvar condylometer and in endometriotic implants, okay? And ND-YAG laser has a greater depth, around 3 to 5 millimeters deep. It is used for endometrial ablation. Earlier, it was used for that. And it is also used for tumor debulking, okay? Class 4 lasers are the ones that we use in medical practice, and these are also the lasers which have highest risk. Okay, so CO2 laser, the chromophore is water, so that means it is absorbed by water, and 0.1 millimeter depth, so only depth, surface, superficial area only, and it does not work in presence of blood. ND-YAG laser, it has deeper penetration, around 3 to 5 millimeters. KTP is a green beam of light. It is absorbed by hemoglobin, that is the chromophore. CO2, the wavelength is 10,600 nanometers. ND-YAG is 1,064 nanometers. KTP is 532. Cell and WIN ablation, we use CO2 lasers. Endometrial ablation, earlier we used to use ND-YAG. Laser plume contains viable HPV DNA. So that is why you're supposed to wear a protective gear when you're dealing with SIN and WIN ablations. And class 4 lasers need eye protection. Talking about diathermy in electrosurgery, again, very, very important, very, very interesting. Diathermy is the use of high frequency alternating current. The frequency is 300 kilohertz to 3 megahertz, okay? 300 kilohertz to 3 megahertz. So the high frequency avoids stimulating muscles and nerves, which would normally cause electrocution at low frequency. So the appliances that we use at home are using low frequency electric current, and that is why they are liable to cause, electrocution for us. But in diathermy, we are using 300 kilohertz to 3 megahertz, which is in that area where the high frequency waves will not cause any stimulation of muscles or nerves. And heat is generated at tissue impedance. What we have monopolar and bipolar diathermy. In monopolar diathermy, we have an active electrode, which is small, and there is a return electrode or a patient plate. Okay, so if you can see, this is the electro generator. It is generating the high frequency alternating current, and it is going to the electrode where we are going to use for the surgery. And then the electricity will transmit through the patient. It travels through the patient to the return plate, and then it goes back to the generator, okay? So the active electrode is small, and the return electrode is attached to the patient, and the current passes through the patient body. The return plate must be properly applied, so the full skin contact is there. If it is not properly applied, then there is a high risk of burns if the contact is poor. And you should avoid this in patients with pacemakers without proper precautions. So now, of course, alternatives are there, and it has a long current path through the body. Talking about the bipolar diathermy, both the electrodes are on the instrument tips. So this is the generator, and this is your instrument, and both the the active this thing, the current which is going to go to the patient and the return, they're both at the instrument tip. So the current only passes between the tip, it doesn't go through the patient. Okay. So it is a short distance that it has to travel. The patient return plate is not needed, and it is safe near vital structures, so there is less collateral damage. It is less effective at cutting and excellent at coagulation, and it is preferred in laparoscopy near ureter and bowel. So you have modes like cut, coagulation, and blend. Cut is sine wave continuous. Okay, it is low voltage and high frequency current which is given. So that is continuous mode. Okay, and it will vaporize the tissue and there will be minimal coagulation. In coagulation mode, it is interrupted. So you give the current, you wait, then you give the current and you wait. So this is the kind of pattern that you see in a coagulation mode, and it has high voltage and intermittent current flow. It will desiccate the tissue and it will seal the vessels, the small vessels, it will seal. Okay, so cut is pure sine wave, low voltage, continuous. Coagulation is interrupted, high voltage, it will desiccate the tissue and seal the vessels. And blend is a mix of both. Okay. Harmonic scalpel is, it uses ultrasonic vibration of around 55 kilohertz, and it will cut and coagulate simultaneously. And there is something called as ligosole now. So that is bipolar diathermy, and it will cause pressure and cause the vessels to seal. So between monopolar and bipolar, monopolar needs a return plate and there is a risk of burn if the return plate is not well applied. For bipolar, both the electrodes on the instrument are there, okay, and therefore it is safer near critical structures. So, slight recall, diathermy, there is high frequency alternating current. Frequency is very important, 300 kilohertz to 3 megahertz. Monopolar has an active electrode and a return plate or the patient plate. Bipolar, it has two tips on the instrument. So both the poles are there. There is no plate, only a short distance the current has to travel. Bipolar is safer near critical structures like the ureter and the bowels. So cut mode, we had told you it is continuous, low voltage, and it vaporizes. Coagulation is high voltage, interrupted. Okay, it will seal the vessels. Patient plate, if it is not properly applied, it can cause burns. So this is a risk of the monopolar diathermy. Harmonic uses 55 kilohertz, and ligosole is a bipolar vessel sealing instrument. And in pacemaker, you have to be very careful if you are planning to use a monopolar. Okay, so let's talk about some SBAs. So diagnostic ultrasound frequency range which is used in OBS is 20 to 200 kilohertz, 2 to 20 megahertz, 200 to 2000 megahertz, 2 to 20 gigahertz, 20 to 200 gigahertz. Okay, so they can give you any kind of these variations, kilohertz, megahertz, gigahertz. You're supposed to know that the diagnostic frequency is 2 to 20 megahertz. Okay, again, just to reiterate the whatever we've discussed, the overall frequency is 2 to 20 megahertz. In abdominal probes, it is 2 to 5 megahertz, which are going to actually be able to visualize deeper structures. Transvaginal probes have a slightly higher frequency and better resolution, so it is 5 to 9 megahertz. Velocity in soft tissue is around 15, 40, and these ultrasound waves are generated by piezoelectric crystals which are present in the ultrasound probe. Higher ultrasound frequency provides better penetration or lower resolution, better resolution and less penetration, both better resolution and penetration, or worse resolution and penetration, or no effect on the image. So what do you think the answer is? You can answer in the chat box. Okay, so the answer is it provides better resolution and lower penetration. So higher the frequency, shorter is the wavelength, and the resolution is better, but the penetration is lower. Okay, so this is a good trade-off because transvaginal probe is closer to the structures, so it is giving a better resolution also, and it doesn't require to go too deep. So it gives a very good image of the neighboring structures of the pelvis. So abdominal is around 2 to 5 megahertz, deeper but lower resolution. I know you all feel that there's a lot of repetition in all our slides, but that is also because we are doing this so that this is like your one-time preparation for this particular module. Okay, you do not need to go through at least this presentation again. Okay, so once we are doing this, these points will be ingrained in you, and that is the intention, and that is our hope also. So third question, thermal index. We spoke about the thermal index in obstetric scanning. So what is the limit that is recommended? Should it be A less than 0.1, B less than 0.7, C less than 1.9, D less than 3, or there is no upper limit, you can do anything? So the answer is less than 0.7. So in obstetric scanning, 0.7 is the thermal index that we see on the screen, and the mechanical index is kept around maybe 1.4. 1.9 is the maximum that it can go for any tissue. Okay, and Alara principle is as low as reasonably achievable. So even if the index is at 0.7, you should use thermal properties which are lower than that. And because of this reason, the Doppler is not usually used in the first trimester because Doppler produces heat. Okay, so the thermal index is increased. Now, in the exam, there can be questions about what kind of damages can ultrasound cause. So it can cause mechanical and it can cause thermal injuries. Okay, so if the question says there is cell lysis and damage to the cells, if the lysis word is present, then it is talking about cavitation and you're supposed to go for mechanical. So these are all linked. Okay, but in OBS scanning, so in OBS scanning, what is the highest risk that we are supposed to be aware of? That is the thermal index. Okay, so just that point needs to be a little bit clearer for all of you. On a T2 weighted MRI scan, CSF appears. So remember the mnemonic, what was it? So how does CSF appear on T2 MRI scans? Is it dark and hypointense? Is it bright or hyperintense? Is it same as the surrounding tissue? Is there a signal void, or it is variable depending upon the field strength? So what was the mnemonic? That water is too bright, TWO bright. So T2, it will become bright or hyperintense. Okay, so water is dark in T1, water is bright in T2. So, and flare we had discussed, it will suppress the CSF to make the lesions stand out. Pregnant woman needs MRI for suspected placenta accreta. What is the best approach? So A, avoid MRI because it is contraindicated in pregnancy. B, proceed with MRI but avoid gadolinium. C, use gadolinium for best details. D, delay until postnatal. And E, use CT instead. Okay, so this is all fresh in our mind. I'm sure you have all got it right. You have to proceed with it, but avoid gadolinium. Okay, so MRI uses no ionizing radiation and is safe in all trimesters. Gadolinium crosses placenta and has prolonged fetal retention. You have to avoid it in pregnancy unless absolutely necessary. MRI is excellent for placenta accreta spectrum. What happened? Am I audible, Sanusha?
Yes, ma'am. Audible.
Okay, so if my voice is breaking or something is a problem, you can tell me here because I don't go back to my phone. Anyway, all right. So if there are late decelerations on a CTG, what does that indicate? So is it a sign of head compression, which is physiological? Is it a sign of cord compression? Is it a uteroplacental insufficiency? Does it mean that maternal fever is there? Or is it a sign of fetal sleep cycle? So late decelerations we had discussed. Any late deceleration is red. It is pathological. Okay, so it is not A, it is B, also not B, it is C, uteroplacental insufficiency. There's a very nice mnemonic that we used to use in our PG days, and that is wheel chop. And now they've come up with a wheel chop mine. Okay, so mine is the management part of it, and that is there on your screen now. So V is variable deceleration. What is the cause? It is cord compression. And how do you manage it? It is maternal repositioning. Then you have E for early decelerations. Then there is head compression. And how do you manage it? That is identifying the labor progress. So if she's in second stage and early decelerations are happening, this is physiological, so you can just overlook it. But watch out. Then you have accelerations, which are okay. So CHOP, O is okay, and you don't need to do any interventions. Then you have late decelerations, which are caused by placental insufficiency, which the question was asking. And what do you need to do? You need to intervene. You need to take action. Whether it is conservative, whether it is definitive, that you will decide by ruling out the acute events, etc. So normal baseline heart pattern at term, is it 60 to 100 beats per minute, 100 to 110 beats per minute, 110 to 160 beats per minute, 160 to 200 beats per minute, or is it variable and there's no normal range? So the answer is clearly 110 to 160 beats per minute. Okay. Fetal radiation dose below which threshold is considered safe. That is, there is no anomaly risk involved to the fetus. Is it 5 milligrays? Is it 50 milligrays? Is it 500 milligrays? 5 grays, or there is no safe dose? We have discussed. Okay, this is the table from talk, but we've not given you the table, but we discussed it. So less than 50 is considered safe in all trimesters. Between 50 to 100 is considered uncertain, but it is mostly safe. More than 100 is got a teratogenic risk. Single X-ray exposure is around less than 0.01 milligrays. In pelvic CT, it is around 25 to 50 milligrays. And in abdominal CT, it is around 8 to 25 milligrays. CO2 laser is preferentially absorbed by which chromophore? So chromophore for CO2, for KTP, and for Nd:YAG is important. So whether for CO2, is it hemoglobin, melanin, water, collagen, or bone matrix? It is water. Okay, so CO2 laser, wavelength is 10,600 nanometers. It is absorbed by water, and it causes only surface ablation around 0.1 millimeters depth, and it's used in SYN and WIN ablation and in condoning matters. KTP, the chromophore is hemoglobin, and its wavelength is 532 nanometers. For Nd:YAG, it has a deeper penetration around 3 to 5 millimeters, and the wavelength is around 1064 nanometers. Bipolar diathermy is preferred over monopolar in laparoscopic surgery because it has higher voltage, which will cut better. It has cheaper instruments. Current is confined between the forceps tips, and there is less collateral damage. It does not require return electrode plate to function, or it requires a return electrode plate. So what is the answer here? Now, this question is made because we want to make a point. Yes. You saying something? Somebody has raised a hand. Sanusha?
Ma'am, please check your WhatsApp or Telegram message. Thank you.
Sanusha, you check yours. Okay. So in this, the bipolar dithermy is preferred over monopolar. So what could be your possible answers? Okay. There are two possible answers here. Option C is also correct. Option D is also correct. Okay. But why will we go for C? Because that is the main safety reason for using a bipolar diathermy. Okay. So bipolar diathermy do not require return electrode plate to function. Okay. So that is why you have to choose a single best answer. Even though there are two correct answers in the question which has been given, you need to go in for the single best option which is available. So that is why this question is very interesting, because it has two correct answers and you need to choose between these two. Okay. All right. So that is, we are coming to the end of our biophysics and data interpretation marathon. And we are just going to now quickly have an look out for the maps of the examples. Okay, so which are the important topics that you must test or study before the exam for this module. So the adult hemoglobin is normally 95 to 98%, and HbA2 is 2 to 3.5%. Fetal hemoglobin is less than 2%. This is a normal picture. In beta thalassemia trait, the HbA2 is more than 3.5%. So if the clinical picture is given or a graph is given, and they have mentioned that the beta HbA2 is more than 3.5%, you will go in for beta thalassemia trait. Now, if a blood picture has been given to you and they have said that the mean corpuscular hemoglobin is more than 27, then it is a sign of iron deficiency anemia, and you will go on to do the iron studies and you will find that the ferritin is low. If the mean corpuscular hemoglobin is 37, then it is a sign of beta thalassemia trait. So you will go in for HPLC or electrophoresis, but HPLC is preferred. And in microcytic anemia, there are two likelihoods. It can be iron deficiency anemia and thalassemia. There are other possibilities, but these are our main two differential diagnoses. Okay. Then we move on to sickle cell disease. In sickle cell disease, only one peak of HbS will be there. There will be no adult hemoglobin. Macrocytosis, B12, folate, and alcohol. Okay, so B12 and folate deficiency and alcohol indulgence can cause macrocytosis. Hemoglobin F is measured by alkali denaturation method or a Betke method. Vomiting in pregnancy, the peculiar thing over here is not only hypokalemia, it also has hyponatremia and low urea. So this triad is very peculiar in vomiting in pregnancy. Refeeding syndrome, it causes hypophosphatemia, that is the hallmark. It can also cause hypokalemia and hypomagnesemia. Refeeding also causes hypokalemia and hypomagnesemia. Hyperemesis, it causes hypocholoremic metabolic alkalosis. Okay. Bile acids, if it is more than 19 micromoles per liter, that is the cutoff for calling a patient of IHCP, intrahepatic cholestasis of pregnancy. If it is less than 19, then you're not dealing with cholestasis of pregnancy, then it is a normal derangement of liver function, normal derangement, or you need to look into it. Bile acids more than or equal to 100 have a high risk of stillbirth. So that is why you must deliver those patients by 35 to 36 weeks. Sinusoidal CTG is a sign of fetal anemia. and it can be seen in parvovirus or rhesus disease. Absent accelerations, but otherwise all the other features are normal. This is a normal CTG, even if it is not a sleep cycle. It is a normal CTG. You do not have to really be concerned about it unless and until there is a development of decelerations. Sleep cycle is normal in fetuses up to 50 minutes. Acute bradycardia, if it is more than or equal to 3 minutes, then you have to send the patient an urgent consultant review. And if it lasts for more than 9 minutes, then you need to expedite the birth. So once the acute bradycardia presents, rule out acute events like uterine rupture or cord prolapse or abruption. And if none of these are present, you can wait up to 9 minutes and then expedite the birth if it doesn't improve. CTG is categorized into white, amber, red, which is normal, suspicious, pathological, depending upon the features. ECG, small square, is 0.04 second. Follicular cyst has posterior wall enhancement. Hemorrhagic cyst shows a cobweb sign, and then it will retract. The detrusor overactivity, there is increased detrusor pressure on filling. Ultrasound frequency is 2 to 20 megahertz. Higher the frequency, higher the resolution, but lower the penetration. TVS has 5 to 9 megahertz. Abdominal probe has 2 to 5 megahertz. Ultrasound velocity is around 1540. Piezoelectric crystals in the probe are the ones which produce these electric radiations, and the ultrasound images produced. What is the safety level? The mechanical index has to be less than 1.9. If it exceeds, it causes cavitation. Thermal index, especially in obstetric scans, has to be kept at less than 0.7. T1, fat is bright, water is dark. T2, water is bright, so water is too bright. Flare will suppress the CSF. MRI is safe in pregnancy as it doesn't involve any radiation, but avoid gadolinium in pregnancy. The baseline fetal heart rate is between 110 to 160. If they give you a post-term patient with anything between 100 to 110, but all other parameters are normal, you can go conservative on her. Variability is 5 to 25 beats per minute, and that is normal. Early deceleration, head compression. Variable deceleration, cord compression. Late deceleration, uteroplacental insufficiency. So wheel chop. I find that very interesting. So in case you forget it in the exam because of the stress, wheel chop. So variable is early like that, okay? Okay, late deceleration is uteroplacental insufficiency. Then the mnemonic for assessing your CTG in your clinical practice is Dr.Sapna Madan. This has been given in NICE, so that is why this is an important mnemonic. Fetal blood sampling is not recommended by NICE, so you must know that it is not recommended by NICE, and you must also know the normal values. So pH more than or equal to 7.25 is normal. pH less than or equal to 7.20 is abnormal, and you need to expedite the birth. If it is less than 50 milligrays radiation exposure to the fetus, there is absolutely no risk. But if it is anything more than 100 milligrays, then it is teratogenic. Pelvic CT exposure to the fetus is around 25 to 50 milligrays. Chest X-ray, fetal exposure is less than 0.01 milligrays, which is negligible. CTPA is preferred over VQ in pregnancy. Again, I'm apologizing for the initial error. CTPA 0.1, VQ 0.5. Okay, so that is the fetal exposure. CO2 laser is absorbed by water. KTP laser is absorbed by hemoglobin. Nd:YAG laser has a deeper penetration. CO2, the wavelength is 10,600 nanometers. KTP wavelength is 532 nanometers. It is in the green zone. Laser plumes contain viable HPV, therefore protective wear. You have to gear up properly. Class 4 lasers are the ones that we use in medical practice. Eyewear is mandatory. Diathermy, the frequency is 300 kilohertz to 3 megahertz. So diathermy frequency and ultrasound frequency, please do not get confused between them, and you must know both of them. Monopolar needs a return plate, bipolar only in the tips. So the current is traveling through a short distance. There is no return plate involved. Cut mode is a continuous low voltage current. So it is going to vaporize the tissue. It doesn't coagulate much. The coagulation mode has interrupted high voltage current and it will seal the vessels. Okay. So these were the most important points in data interpretation and biophysics, and also the questions which had come in the July 25 exam. So I hope this was useful for you. If you have any questions, please leave it in the chat box and we will get back to you with the answers tomorrow. If there is any confusion regarding any point, you can put that also. So if I have time tomorrow, I will take it up in the session, and I will see you in the physiology session tomorrow. It is a very, very important module, okay, because in paper 1, anatomy and physiology, they take up the major chunk of the paper, and there's a lot of overlap between clinical management, between physiology and endocrinology, etc. So you must attend that session, and I'll see you all tomorrow. So over and out from me now, and all the best. Keep studying and do join us tomorrow.